Доброго вечора, шановні учасники. Вітаємо всіх, хто сьогодні свій вечір присвячує новим знанням, якимось відкриттям, пошуку нових навичок і нових практик. Отже, Координаційний центр з психічного здоров'я Кабінету міністрів України анонсує новий проєкт «Професійний розвиток у сфері ментального здоров'я. Знання, досвід, практики». Ми намагаємося створити простір, де спільнота, професійна спільнота з усієї країни, з будь-якої точки нашої країни, може отримати доступ до найкращих міжнародних знань, інструментів і практик. І, власне, у прямій розмові з тими, хто ці підходи створює, впроваджує і досліджує. І ми вже бачимо, що анонсована нами зустріч відповідає на реальний запит. Лише на цей вебінар зареєструвалось понад 3000 учасників. А це показник не лише інтересу, а ще й того, що ви дуже відповідально ставитесь до того, що робите щодня. І не зупиняйтесь на навчанні. Сьогоднішня зустріч присвячена науково-доказовим методикам психотерапії посттравматичного стресового розладу. Я дуже вдячна нашим партнерам з Техаського університету, які 3 вебінари готові присвятити цій темі. Вони це роблять абсолютно безкоштовно для України у свій вільний час, і наша вдячність не знає меж. Сьогодні з нами доктор Грег Мюллер, психолог, доцент кафедри психіатрії та поведінкових наук у Dell Medical School при Університеті Техасу в Остіні. Вітаємо, Грег! Я знаю, що ви вже готові. Дякуємо вам за те, що доєдналися. І декілька організаційних питань. Програма вебінару складається з 1 години лекцій та 30-хвилинної сесії питань-відповідей. Ви можете писати ваші запитання по ходу лекції, і наприкінці я буду їх зачитувати для доктора Мюллера, і він дасть відповіді на них. Ті, хто не зміг доєднатися до зустрічі в Zoom, зможуть дивитися онлайн-трансляцію на Фейсбуці Координаційного центру з психічного здоров'я Кабінету міністрів України. І також запис цього вебінару буде доступний на сторінках Координаційного центру на Фейсбук та на сайті ТИЯК. І ви зможете в будь-який момент переглянути пізніше. Нагадую, що програма ТИЯК, всеукраїнська програма ментального здоров'я ТИЯК, є ініціатива першої леді України Олени Зеленської. І сподіваюсь, що сьогоднішню зустріч не зможуть перервати повітряні тривоги. Тож починаємо. Передаю слово доктору Грегу Мюллеру. Пане Грег, прошу до слова.
Wonderful. Can you all hear me okay? All right. Wonderful. So thank you all for joining me this evening for my presentation titled Evidence-Based Psychotherapy for PTSD. We have a lot to cover. Like we said, my plan is to lecture for about the next hour and then open up the floor to you all for relevant questions that you have. And so to begin my presentation, I don't have any known disclosures at this time, but I want to give significant acknowledgement. I would not be able to do this presentation without the work of 3 groups. Credit to Drs. Edna Foa and colleagues for their contribution to the development of prolonged exposure therapy, to Dr. Risek and colleagues for their work related to cognitive processing therapy, and lastly to Drs. Denise Sloan and Dr. Brian Marks and colleagues for their work developing written exposure therapy. These are the 3 primary evidence-based interventions that we're going to be talking about this evening. And so I know that we have that introduction. To give you a little bit more information about myself, my name's Greg Muller. I'm an assistant professor, licensed psychologist. I work at the University of Texas at Austin. in the United States. And part of the reason that I'm coming to you tonight is to discuss my expertise in using exposure-based interventions. My specialty is in the treatment of anxiety, obsessive compulsive disorder, and trauma. I am also a member of the American Psychological Association's Division 19, that's the Society for Military Psychology, and I'm working to build my expertise treating military personnel and first responders. I have a blended role. I do clinical work, working in 2 clinics, the most relevant of those clinics being the Trauma Recovery and Research Center here at Dell Medical School. I also supervise psychiatry residents, teaching them how to do psychotherapy themselves. I have a variety of research projects, the most relevant of which is the D43 Ukraine project that is in collaboration with my colleagues at Texas A&M University. You will hear a presentation in the future from Dr. Israel Lieberson and Dr. Tanya Nicholson. So let's talk about what we're going to cover for the next hour. So we have 3 main parts to this presentation. The first looks at the difference between stress and trauma. Very quickly, we'll talk about what post-traumatic stress disorder is, how people recover from PTSD, and when people get stuck in PTSD, what are the interventions, the evidence-based interventions that we can do to help them recover, to help them return to life and happiness. And then we're also going to briefly talk about how to adapt these interventions for different populations that you might work with, and then open up the floor to any questions that you have. The goal of this presentation is not to make you a total master, a total expert. It's to get you started in your learning journey to use these interventions with your clients. And so I start this presentation by asking the question, is stress bad? I often, with the patients that I work with, talk about the difference between stress and trauma. And oftentimes my clients with PTSD, I ask them, is stress bad? And they usually say, yes, stress is always bad. There is no good that can come from being stressed. But I challenge them, because all stress is our body telling us there's something important that might be happening, and you might need to take action to keep yourself safe. I think of trauma, psychological trauma, as a stressor that is so large that the body cannot adapt to it effectively in real time. And when the trauma is significant enough, we see a common pattern of symptoms. There are 4 main symptom categories for post-traumatic stress disorder that we are looking for as clinicians. The first of which is intrusive re-experiencing. This is our clients talking about nightmares back to the traumatic event. Flashbacks. The flashbacks are almost like a movie that's playing out before their eyes. They feel like they are back in the traumatic situation again. We also look for a pattern of avoidance, avoiding objects, people, activities, any reminder of the traumatic experience. There's also changes in the client's thoughts and emotions. Clients describe feeling intense fear, intense anxiety, intense sadness, or nothing. They feel numb. And then there's also changes in arousal and reactivity. Clients feel hypervigilant. They are constantly looking for danger, or they crash and they are not able to feel anything. They're not able to interact with their environment. And as I'm sure you're already aware, it's very common that there are comorbidities between PTSD and other mental health disorders. So common examples are depression or substance use disorder. In my own work, many of my clients struggle with alcohol use disorder who also have PTSD. Now, in the United States, we do not have an active conflict here, but our prevalence rate for PTSD in our population is 5%. This will obviously be much higher in Ukraine, with females tending to report with more PTSD symptoms. My thoughts are that men may have more PTSD symptoms, but they may be reluctant to report them because of stigma. So I show you this graphic too as we begin this learning journey to get you to start thinking about recovery trajectories. In the DSM says that we can diagnose PTSD after 4 weeks, but this is not technically accurate. We can diagnose PTSD after 4 weeks, but very often clients are in a process of what we refer to as natural recovery. So I'm going to take you through several of these trajectories that clients can experience following a traumatic experience. So in the best case scenario, we're looking at the top line here. So a traumatic experience happens, but our clients are resilient. Their functioning may drop temporarily, but overall, they basically remain unaffected by the trauma. Very often, clients, we're looking at this third green line here, clients will have a decline in their functioning after the trauma, but then they will engage in a natural recovery process. This is a recovery process without requiring any therapy or intervention to improve. Most people within their life will have at least one traumatic experience, but the majority of people do not go on to have what we think of as a post-traumatic outcome. And this second green line, and if the client experiences a trauma and their functioning declines, maybe a better outcome is that they have what we would think of as post-traumatic growth. These are the clients that we work with where they say, I feel so much more grateful for my life. I feel like I learned more about who I am, and I'm happy to still be alive. And their functioning actually increases after the trauma. But for many clients who have a post-traumatic trajectory, they experience delayed or chronic symptoms. So again, this is just a graphic meant to highlight the idea that we need to be thinking about recovery trajectories. I am always asking my client, what can we do to promote your recovery? And what are the activities of recovery that are important for you? So we talked about with PTSD symptoms that avoidance is a huge part of PTSD. PTSD is referred to as a disorder of natural recovery. A disorder of failed natural recovery. And PTSD is also referred to as a disorder of avoidance. I very boldly refer to experiential avoidance as the most important idea in all of psychology. I am showing you Wikipedia because I know this is something I do with my own clients. I know that they have access to this. So let's take a look at experiential avoidance. So experiential avoidance, broadly defined as attempts to avoid thoughts, feelings, memories, physical sensations, and other internal experiences, even when doing so creates harm. So simply said, clients try to take care of themselves through avoidance. They try and manage their trauma symptoms through avoidance, and that unfortunately maintains and can increase their symptoms. And this is so important because a lot of what we think of as mental health disorders are actually disorders of avoidance. So major depressive disorder, people have overwhelming sadness, guilt, low self-worth, and they isolate or they have thoughts of suicide. Suicide is thinking about suicide very often is an avoidance strategy. One of my clients I was talking with before said, I don't want to die, but I don't want to be alive anymore. PTSD, people, they experience a trauma, they avoid those reminders because those reminders bring out their PTSD symptoms. Social anxiety, panic disorder, obsessive compulsive disorder, substance use disorder, all disorders of avoidance. And so within PTSD, I refer to this as the PTSD loop. So a traumatic event occurs and there's a belief shift that occurs for people where they see the world as more dangerous and they see themselves as less competent. And the person becomes reactive to trauma symptoms. And that dotted line means time passing. So the trauma event happens, time goes on, and the person returns to their normal life. But every time that they encounter reminders, people, places, activities, objects of the trauma, they begin to have trauma symptoms and they avoid this. And that avoidance works to manage their anxiety temporarily, but they begin to avoid situations that are reasonably safe. And clients experience this loop of avoidance. And the problem with avoidance is that it prevents them from processing the trauma, memories, and thoughts. They never learn that these situations are low risk and that they can handle them. And it prevents changes in unhelpful beliefs. The symptoms persist into time. And clients go around in this loop over and over and over and over again. And so a huge part of recovery for our clients is how can we give them a healthy relationship with avoidance? How can we help them move towards what they are afraid of so that they can recover? And for the sake of time, this talks about fear structures and trauma memories. I'm going to skip over this for the sake of time, but you should have access to this presentation if you want to look at more so at that. And so now we step into the idea of combat-related PTSD. So people in conflict zones obviously are at a higher likelihood of developing conditions like anxiety, depression, post-traumatic stress disorder. And obviously this is common in Ukraine as well with the populations that you're working with. This is a map from the US Council on Foreign Relations showing different conflict zones where people are experiencing trauma and they likely are also experiencing PTSD as well. And so these are the best results that I was able to pull up right now. Prior to Ukraine's full-scale invasion in 2022, it was estimated up to a third of Ukrainian civilians and military populations were suffering from PTSD. It is very likely that this number has gone up significantly since the full-scale invasion occurred. And even if people are not experiencing PTSD, they've been exposed to combat and war-related traumas. Example of these traumas could include conscription, combat exposure, the deaths of loved ones, being displaced, or in the most severe cases, detention, abuse, and torture by security forces. And this speaks to different elements within PTSD recovery. PTSD recovery, I think of it as a learning intervention. I'm constantly asking my clients during therapy, what are you learning through this treatment process? And there's three primary theories that go into this, or research foundations: emotional processing theory, fear extinction, and cognitive processing theory. Okay, so now we are moving away from the foundations of PTSD into the treatments themselves. The three interventions that we're going to talk about are prolonged exposure therapy, cognitive processing therapy, and ridden exposure therapy. And my learning goal for you all tonight, again, I do not expect you to be a master of these interventions by the time we are done. It's just meant to build your understanding and interest in these interventions so that you can continue your learning. So starting with prolonged exposure therapy. So there are three main components of prolonged exposure therapy. PE focuses very heavily on assessment and the education of our patients. Before we start treatment, we are determining, is the person that I'm working with, do they have a true diagnosis of PTSD? The two main therapeutic activities after this are developing what we refer to as an exposure fear hierarchy and the completion of imaginal exposures. The imaginal exposures of the retelling of the trauma memory. We're going to talk more about this later in this presentation. Cognitive processing therapy is another very popular intervention, evidence-based intervention for PTSD. PE and CPT have similar efficacy, but CPT focuses very heavily on the beliefs that people picked up as a result of the trauma and how are they thinking. Cognitive processing therapy is changing the way our clients think about the trauma. A major strength of CPT is the 5 trauma themes. So in later CPT treatment, there are modules on trauma themes: safety, trust, power control, esteem, and intimacy, because we know that clients are affected, that these areas of a client's life are affected because of the trauma. And there's also ridden exposure therapy that is an emerging intervention. Ridden exposure therapy emerged from prolonged exposure therapy, and it claims that it can cure PTSD with it, or resolve PTSD in 5 sessions. I was very skeptical when I first learned about this, but I'm very optimistic, and our research group is actively working to study ridden exposure therapy within Ukrainian populations. It obviously has the huge benefit of finishing treatment much faster, which, especially for military personnel that have to redeploy, it can be extremely beneficial, is what we're thinking. So let's start exploring these different interventions. So prolonged exposure therapy, PTSD, so we refer to it as a disorder of failed recovery. People use avoidance to cope, but that coping causes them trouble. And the way that people heal within prolonged exposure therapy is through using approach-based coping strategies, moving towards the fear. I think of prolonged exposure therapy as the science of bravery. There's 2 main activities within prolonged exposure: the completion of in vivo exposures and imaginal exposures. The PE is a 12-session treatment experience for people. And I think a lot of the Ukrainian clients that I've coached people in treating, there's a lot of concern that therapy needs to go on forever. That's not what we're talking about. My goal for all my clients is to help them recover so that they can fire me and that they can move on from therapy. I do not believe that therapy has to be something that they do forever. And I think a lot of clients take comfort in this. And so again, the two main activities. So the in vivo exposures, that involves the client moving towards the things that they're afraid of. You're developing what we refer to as a fear hierarchy or a fear list. What are the places, because of the trauma, what are the people, places, activities that the client avoids? And by doing these activities outside of session, the individual learns that these situations are not as dangerous as PTSD makes it seem for them, and that they can tolerate the anxiety that comes from being around these things. And then the imaginal exposure, that is the retelling of the trauma memory. It helps the client process the memory to put the memory in context. That is the main activity that you are doing in session with your clients. This is the repeated retelling the story over and over and over and over again until you're teaching the client's body that they can tolerate this story. And so who should get PE treatment? PE focuses very heavily on the assessment of PTSD because it's very important that the client has a memory of the trauma with a beginning and a middle and an end. Now, clients can have multiple traumas. Their memory does not have to be perfect, but there needs to be at least some structure to the trauma memory. A patient that would not be a good PE candidate would be someone that says that they want to do PE therapy for their entire childhood. We need specific moments, specific memories to work with. And so this is an example of what a hierarchy could look like if you have not previously done this work. So one edit that I would make to this slide, so in prolonged exposure therapy, so that column, that yellow list, that is the level of distress that a client experiences. So in the one edit I would make to this is in PE, we use a scale from 0 to 100. So 0 is, I feel no anxiety doing this. 50 is, I feel some anxiety, but it's manageable. And 100 on the scale is the most anxiety that somebody could possibly experience. So I created a hypothetical hierarchy for a patient that was involved in a school shooting. So different exposure activities that the patient would do outside of session would be writing a short story about the traumatic experience, maybe watching a YouTube video about firearms, reading a story about the school shooting that happened, and maybe a harder exposure activity would be going back to the school where the event happened or visiting the grave of a friend that was lost in the shooting. That's a more challenging activity that might happen. So this is in early PE therapy, you're helping the client to build this list related to their trauma. So for the veterans that I work with, common activities are to look at photos of their time in military service, perhaps to wear their uniform again. If it's safe to go back to the places where the trauma occurred. Again, we need to be smart. If those places are still in active conflict, it might not be safe to go there, but challenging them to move towards what their body says is dangerous. So that's the fear hierarchy element of treatment. And then for the imaginal exposure, so that's the retelling of the trauma memory, the specific event. So this is an example of what I might say to my clients doing this work. So settle into your seat, get comfortable, close your eyes, soften your gaze, tell me the story of what happened. Tell it in active tense as if it were happening right now. Add as much detail as you can and imagine it in your mind's eye as clearly as possible. And then what's happening is you're having this client tell this story over and over and over and over again. You're having them practice repeatedly to confront the story so that it does not bother them as much, that their anxiety goes down. And an important part of this is that the client is recording this audio in session with you. Because for homework, one of the assignments is that they're listening to this audio again, so that they're doing exposure work outside of session. And I don't know how, I can't speak to what your practices individually looks like. In the United States, we have about 60 minutes to work with our clients. And so my PE sessions are very structured. We have an agenda, and we're moving through that agenda very swiftly so that we're getting the most from treatment. So part of session is the retelling of the trauma memory. And then there's a processing phase that happens after the imaginal exposure. So the client tells their story of what happens, and then I say something like, so what was that like for you? What was that like for you telling me your story? And then you're helping the client to process that trauma. You're discussing with them, how has this impacted your life? This is a learning intervention. The more that the client shares the story, they feel less shame. They're able to make sense. You're able to talk about what this trauma teaches them about how they can live their life now. It's very important to also talk about, we're not telling the client what to believe. We are not telling the client what to believe. We're helping the client to decide, what conclusions do I need to take from this story so that I can live in a healthy way? And so there's different ways that processing can go for clients, depending on what their trauma is. So we have the two elements. We have developing the hierarchy, doing the imaginal exposures in session. So with a client, maybe you're on session, you're in the middle or late stages of prolonged exposure. Another feature of prolonged exposure is what we refer to as hotspots, in quotes. So the way to think about hotspots are, if you have a stove at your house and you touch a burner, right, you're going to immediately move your hand away from that hot burner. The hotspots in the trauma memory are the most intense, anxiety-producing. They're the parts of the memory with the most danger. I'm going to show you an example of what that looks like in a minute. It's very important that we help our clients challenge their hotspots, because if they can handle the most intense moment of the trauma, they will be able to function better in daily life. And so hotspot work in PE begins around session 5 or 6, but you can don't wait to do it too long. You need, at least by session 8 or 9, we should begin doing hotspot work. And if the client has multiple hotspots, that's completely fine. You can challenge them one by one until they start to resolve. And so if hotspots is still confusing, here is a example of what I mean. And so remember, we talked about how in PE, we need very clear, a clear memory. So, and we use the example of a bookend for hotspots. So what is the beginning, the middle, and the end? When did the trauma start? When did the danger begin? The hotspot is that most difficult moment. And then when was the danger over, the ending of the trauma memory? So I give you a very clear example here of a combat situation where a soldier takes fire. The hotspot for this particular soldier would be watching their comrade, their friend, die and being unable to save their friend. This is likely a hotspot for the soldier because it's likely the moment that they felt the most helpless or was encountering the most violence or danger. I'll use another example. So for a sexual assault, as an example, the hotspot for most people is the actual moment of the rape or the assault itself. And wanting to help the client to process that part of the memory is very important. So another thing to think about as well with the imaginal exposure, so the retelling of the trauma memory, is the idea of engagement. So the best way to understand this, I think, is to start with over-engagement. So by over-engagement, we mean things like dissociation, where the client is flashing back, perhaps to, like, you're in session with the client, they're telling you their story and they're having flashbacks, or they're not able to speak to you because they're dissociating. So that is when the client is over-engaged, when they're emotionally overwhelmed by the telling of the story. And then we have under-engagement. Under-engagement is when the client is showing you no emotions. It looks like the story is not upsetting them at all. And so there is this middle ground that as clinicians, we're trying to bring our client to, where they are expressing their emotions, they're expressing their thoughts, they're being vulnerable, but they're not so overwhelmed that they're not able to learn. The question here related to engagement is, how can I help my client learn from this? We want them to engage with their emotions, but not too much. And we do the best we can, and we need to challenge our clients when they're under engaging and support them when they're over engaging. And a very simple example of this, when I have clients that are over engaging. In session, I have a stress ball and I play catch with them. We pass the ball back and forth, and that keeps them from dissociating and keeps them in their feeling like they're inside of their body and they're able to engage in session. And I'm happy to talk about this concept later on if there's questions later. So we're coming to the end of our PE segment of this lecture. If you're sitting here wondering, okay, so I want to start doing this, there is a free app, a free phone application, PE Coach 2. I would encourage you to download that if it's available in your region. That has great resources for you and your clients that you can immediately start learning more about prolonged exposure. So we're moving now to our second evidence-based intervention, cognitive processing therapy. And like I said before, we have equal evidence that both prolonged exposure therapy and cognitive processing therapy are equally effective in treating patients with PTSD. Cognitive processing therapy is also a short-term intervention between 10 to 12 sessions. It's not meant to be clients are not meant to be in therapy forever. There's a very specific protocol we're following. Again, CPT focuses on the cognitive element of recovery. This can be done individually or in a group. And that is a manual that you can use if you are interested in learning more created by Dr. Risek and colleagues. And so this talks about the foundations of cognitive processing therapy. So it speaks to the idea that through our lives, we use our senses to collect information, our vision, our hearing, our feeling. And we use our senses to understand the world and to control the events around us. And a large part of cognitive processing therapy is related to what we call the just world belief. So this is a belief that we are often taught as children, which is that good things happen to good people and bad things happen to bad people. The problem with this is that is for people who experience a trauma, if they still have this belief from childhood, the conclusion that they come to is, I must be a bad person because this trauma happened to me, which is obviously very often not true. And trauma shatters this belief and can contribute to PTSD symptoms. And so beliefs are a huge part of cognitive processing therapy, and trauma can either confirm or destroy previous beliefs. So this is an example of a sexual assault, for instance. So if a person thought that most men are trustworthy and safe before the trauma, but then a sexual assault happens after the trauma, maybe their conclusion is all men are dangerous and I must protect myself all the time. Or if before the trauma, the person already believes that, they already believe that men are dangerous, then once a trauma happens, they say, yes, I knew it. I knew it was true. This trauma confirms my belief that all men are dangerous. And so the trauma symptoms that people experience come from being unable to process and integrate new information to challenge these beliefs. So CPT is all about how can we give people new ways of thinking and to challenge these trauma beliefs that they have. Again, CPT is a 12-session protocol, usually 50 minutes. And there's a lot of education and modules that you are doing with your clients. So early CPT is giving them psychoeducation on PTSD, setting goals, and talking about the importance of homework assignments. There are many worksheets and handouts that you are giving to the client and doing with them in session. We'll talk about what some of those activities are, teaching them very directly how to challenge their beliefs, challenge their thinking. And then later CPT looks at those 5 trauma themes. So trust, safety being examples of that. How can we help people not relapse after treatment concludes and help them plan for returning to their life in the future? So this is one example of a handout that I do with my clients in session. So a very important part of early cognitive processing therapy is related to stuck points. So stuck points are rigid ways of thinking that have developed because of the trauma. So different examples here. I must guard myself at all times. I must control everything that always happens to me. There is no way that a civilian could possibly understand what I've been through. Or it's my fault that the trauma happened to me. And so it's very important in early cognitive processing therapy that we help the client to identify what are their stuck points so that we can challenge them in treatment. And this is, I should also specify, these are not all the stuck points that a client can have. This just gives you an example of what some of those may look like. There's two different types of stuck points. Stuck points about the past, assimilated stuck points, or stuck points about the present moment or the future. So, and we call those over-accommodated stuck points. So those first kind of stuck points are related to guilt and blame. If only I had, I should have, if only. Guilt about the past. The over-accommodated stuck points are conclusions about what the present or the future may look like. So never, always, no one. So these would be things like, I can never trust anyone ever again because of the trauma. I must always protect myself. No one will ever understand what I've been through. And they're often related to the 5 CPT themes that we had talked about before. So identifying stuck points is important before we can begin treatment with our clients. We talked about this. This is just another example of how this is across those 12 sessions, just giving you another example of how a CPT treatment experience might go. Those trauma themes begin at session 8 and conclude at session 12. And then we graduate our client. We help them move towards a future that they can be excited about. So how does CPT help people, if that's not already clear? So it helps them challenge their avoidance. Similar to PE, challenging avoidance is very important in cognitive processing therapy. And it helps them to dissipate natural emotions and change manufactured emotions. So natural emotions are emotions that we have without thinking. So somebody gives you a gift, you might become happy. You learn that somebody died, that might make you sad. You're not thinking about them, your body is just responding. Manufactured emotions are emotions that occur because we're thinking about them. Shame is an example of that. People are thinking about the past, they're thinking about the trauma, they experience this very negative, intense emotion. And so we're helping the client to express those natural emotions so that they don't need to carry the burden of those emotions, and we're helping them to not create manufactured emotions like shame in the way that they have been. And we're also helping the client to not overgeneralize their thinking from what I would say for number 4 is just because the trauma happened does not mean that we need to hold on to these stuck points. These stuck points, you may think these stuck points are keeping you safe, but they're actually holding you back and keeping the PTSD in your life. And so, again, there are many, many, many worksheets and handouts that I print and that I'm doing in session with my clients. I'm assigning them for homework. So an important consideration with CPT is you ask your client, are you okay with doing worksheets? Sometimes clients want to get better, but they're not interested in this treatment approach. And so I know that my own practice has benefited from having training in multiple types of trauma interventions because it gives a client a choice about what their healing journey might look like. So this gives you a list of a variety of handouts and worksheets that you can do with your client during CPT. Okay, so resources. So CPT is available in Ukrainian. And if you go to cognitive processing therapy for PTSD.com, you can find this in English. You can find this in other languages as well. My understanding is that this is a free resource that you could access today if you wanted to start learning about CPT more. This is another example of this is an early therapy handout in CPT. This is called the ABC worksheet. So we're teaching our clients to challenge the way that PTSD causes them to think. We're helping them identify what is the connection between the events that happen in your life your stuck points and your emotions so that you can begin to challenge those and think and feel differently and feel better. This is a worksheet that we do at the very end. So cognitive processing therapy, you're teaching a variety of small skills that come together beautifully at the end of treatment. And so at the end of treatment, the clients are hopefully skilled in using this worksheet to identify their stuck points, identify how to challenge their thoughts, developing new thoughts, and then hopefully changing their emotions. Again, I do not expect you all to be experts at this yet. I'm happy to take questions more about this at the end of this presentation. And we already talked about the trauma themes. This just lists them out again. The CPT trauma themes work begins around session 8 in CPT. This is an example of one of those trauma theme modules. This is the trust theme. So for many people, especially people with PTSD, they see trust as black and white. I'm either totally trusting a person or they are totally untrustworthy. And this module helps people to challenge, can we think about trust as a continuum? People that we trust not at all, a little bit, to extremely. It also challenges how we think about who we give trust to. So an example of this, I have a good relationship with my mother. So I would ask my mother to help me with a problem, but I would not trust her to fix my teeth if I had a dental problem. In the same way, I would trust a dentist with my dental care, but not with one of my life problems. So we trust different people in our life with different things. This worksheet is helping people to think about trust in a new way. Okay, so if you're interested in CPT, again, there are more free resources. I would strongly encourage you to look at the website CPT for PTSD and to look at that free application, that free phone application that you can use in session with your clients as well. So we're coming to the end of CPT, and we are discussing our last evidence-based intervention, ridden exposure therapy. One of the advantages of ridden exposure therapy, like I said, is that it's only 5 sessions, and we have seen that clients can significantly benefit if this is an intervention that they're interested in. It's not, again, it's not a new treatment. It is a repackaging of imaginal exposures. It's meant to be faster. So now again, clients, it's all about what the client wants in terms of therapy. Clients might be interested in treatment, but they're not going to want to physically write about their trauma. So then maybe CPT would be better for them. But the benefit of ridden exposure therapy is that it's in the past tense, as opposed to an active present tense. There's also no therapy homework. That's a huge advantage. And most of the sessions are the client writing continuously about their trauma. And there's research that is emerging that shows that ridden exposure therapy is similarly effective as cognitive processing therapy as prolonged exposure. And it's been indicated in working with veterans as well, which for many of you is probably a strength of using this intervention. We can hopefully get our veterans better faster through ridden exposure therapy. And so similar to prolonged exposure, you're identifying the trauma memory. What is the beginning of the trauma, the middle of the trauma, the end of the trauma? And it's very important that the story, because the client is writing about their trauma, it's important that they can finish writing the story of what happened to them within 1 or 2 sessions. The story can't be so long that they're not able to actually complete that in therapy with you. It's also very important that it's a criterion A trauma, a threat to their life or to the life of someone that is close to them. We do not want to do ridden exposure therapy with smaller life stressors like a job, as an example. That might be one example of not using ridden exposure therapy. So, and here is also an outline of what ridden exposure therapy might look like. So let's start at number 2. So you're collecting the client's SUDS. So the SUDS are those units of distress, 0 to 100. How nervous are you before you begin this writing? There's also a very clear writing prompt that you're reading to the client before they start writing. Then the writing begins. The client is writing continuously for 30 minutes. If they stop before 30 minutes, ask them to continue. If they finish their story before the timer is up, have them rewrite it. And then at the end of the writing, you collect their sons. Okay, so how stressed are you now that you wrote the story? And then you do processing. So what was this writing activity like for you? And again, the advantage of written exposure therapy is that there's no homework. The client just gets to leave session and go home, but you as the therapist need to read what the client wrote so that in the next appointment, you can give them direct feedback. You can coach their writing more effectively. So here's an example. You are saying this to your client directly before they begin writing. So this is for the first writing activity in written exposure therapy. So for your first writing session, I'd like you to write about the event starting at the beginning. You can begin with the moment that you realize that the trauma was about to happen. And then you're coaching the client, add as much detail as you can, add as much emotion as you can, write about the thoughts that you're having. We want this story to be as much detail as possible so that the client will most benefit from this activity. And there's different prompts that you're giving at each appointment. It's a different writing prompt. So, so how do we give feedback as therapists? So after the session ends, the client gives you their writing, and then you need to read it so that you can coach the client. So usually what we're, so in the next appointment, usually what we're telling the patient is, I want you to add more emotion. I want you to add more detail about what happened. We want this to be a really detailed story. And so that is the conclusion of our written exposure therapy unit. So we've covered our 3 interventions. And so the question that I usually get asked is, okay, so I want to use these interventions with my clients, but I have challenges. And so we're going to talk for a minute about how do we adapt these interventions for the clients that we worked with? Because we can have an intervention that's great, but we need to make sure that this intervention is the right intervention for the client that we're working with. It's very important that we're not changing the intervention too much, that it doesn't work the way that it needs to. So let's look at some examples of this. So with the Ukrainian providers that I consult with, there's a lot of challenges with working with patients, right? So patients may be not interested in doing therapy. They might need to redeploy very quickly. They might have comorbidities like alcohol use that complicate treatment, or they might still be in a situation where they're being traumatized. And so I give the example of prolonged exposure. How can we adapt prolonged exposure for our clients? So we can focus more heavily on doing the in vivo exposures, the actual activities, like looking at photos, going back to the places that the trauma happened, if that's safe. You can do the sessions a lot slower. So take more than 12 sessions, tell the stories slower, you're not rushing through them. Or you can use what we call a masked prolonged exposure approach. So that could be doing therapy for several hours, doing several therapy sessions in one day. So one of the most aggressive ways to do prolonged exposure therapy is 3 sessions a day for 5 days in a row. Again, most people are not doing that, but that may be necessary for some clients that can tolerate that treatment. So these are just some examples of adaptations in prolonged exposure. So we're coming to the close of our presentation. I'm going to open it up to some questions, but some final thoughts. So 3 main things from this presentation. The recovery process. PTSD is a failure of natural recovery. By approaching the things that our clients are afraid of, that will allow them to recover. It will allow them to remove the shame and blame that they feel about the events that have happened to them. It's very important that we use evidence-based interventions to support PTSD recovery, and adapting the intervention for our clients is very important, so that they're able to use the interventions in a way that works for them. And this is a quote that I like. I think about this often in the work that I do. Moving on isn't about forgetting every painful thing that occurred. It's about learning to live with the memory without allowing it to dictate your life. It is a beautiful moment when you discover that you can live with some memories that hurt you and still experience joy. This is a process of healing. And so we're going to open it up to questions, but I want to directly thank my colleagues and friends at Texas A&M University, our colleagues both in the United States and around the world. Credit to our funding agency, the NIH Fogarty Program, for supporting our work in training providers in Ukraine. And I also want to spotlight, we're working to form an organization called the Global Trauma Recovery Network. This is designed to help support adults with trauma, children and families, and also to help increase the number of providers in the world that are trained in evidence-based trauma intervention so that we can give the most healing to as many people as possible. And a special thanks to you for being here tonight. And if you're interested in learning more about my work, that is my personal website as well. And now it's time for your questions. Thank you for your attention.
Дякую, доктор Мюллер. Дякую за цікаву лекцію. Я хочу повідомити вам і нашим всім учасникам, що ми сьогодні мали максимальну кількість, яку сьогодні дозволив нам Zoom доєднати до цієї зустрічі. Це 300 учасників були з нами постійно в Zoom, і ще 180 на трансляції на Фейсбуці Координаційного центру. Ми маємо питання, будемо спробувати з вами вкластися в ті 30 хвилин, які лишилися, і щоб ви мали можливість на них відповідати. І перше, я хотіла би ще додати, що серед наших учасників і психіатри, і психотерапевти, і психологи, ті, які працюють з пацієнтами, ті, які вже мають досвід роботи з пацієнтами в різних станах і мають такі живі кейси, на які не завжди можна знайти відповіді одночасно, тому що ми знаємо, що травма війни в Україні унікальна, війна жорстка і як для цивільного населення, так і для тих, для людей, які мають бойовий досвід. Тому переходимо до запитань. І перше, з чого би я хотіла би розпочати, це попросити вас уточнити назву додатку або сайту, який ви в презентації вказували, як додаток з корисними ресурсами. Десь в першій частині, якщо можна і ви швидко знайдете, то ми виведемо це з вами на екран, щоб наші колеги могли зафіксувати. А я тоді, якщо я паралельно продовжую з питаннями, чи дочекаюся, поки ви покажете той слайд?
Why don't we wait for the slide? One moment for that.
Добре. Давайте тоді рухатися крок за кроком.
So there's two applications.
Окей.
Yeah, so the two apps, one is PE Coach 2, that is for learning about prolonged exposure. And then the second app is PE Coach as well. I'm sorry, CPT Coach as well. If you type in CPT and PE into the app store on your phone, I would assume that will come up.
Дякую, пане Грег. Я нагадаю нашим учасникам, що запитання ви можете ставити в Zoom або в коментарях під онлайн-трансляцією на Фейсбуці. І починаємо. Питання від Марії Супрун. Скільки часу може бути клієнт в терапії при ПТСР?
Do you mean in one session or the total treatment series?
Ні, як довго загалом, так.
Yeah, so for the series. So the way that I run my clinic is that I block out all the appointments ahead of time. So I think about my own clinical work similar to a physician. So a physician prescribes a 30 to 90-day course of medication for people, I prescribe 12 sessions of therapy to start. And then after that first dose of therapy is done, I ask the client, how are you doing? And if it's necessary, then I will also re-prescribe more therapy. So I think about my role as a clinician similar to a physician with medication. But as far as ultimately, I think it's an individual question. How long should my client be in therapy for? What I'm always asking when I'm uncertain if I should continue a client in therapy, I'm asking, is my client still learning? And what are our goals at this moment? And are they recovering in a way that's important for them?
Дякую. Ірина Кириченко запитує, що клієнт далі робить з цими листами? Це працює як наративна терапія? Листи, техніка написання листів.
Yeah, if we're talking about written exposure therapy, the clients do not hold on to those stories. They are giving them to you to use. And so that is one of the major benefits of written exposure therapy is that they can go home. There's no homework after the session. There's nothing they take with them.
Дякую. Оксана Фіцак запитує, чи застосовуєте ви фармакотерапію поряд з сесіями?
So I cannot prescribe. So that's not something that I do within my role, but I work very closely with my colleagues here to have that conversation. And so the way that we decide that is, can the client tolerate treatment without medications? And it's an individual decision. I do not jump to medications right away. I tend to encourage my clients to try therapy without medication, but I will not necessarily stop them from doing that if that's the right decision.
Дякую. Пані Василина ось так ставить вам питання. З якого віку можна застосовувати дані методи при роботі з дітьми? І чи можна? Ну, якщо готові про дітей сказати, прошу.
Yeah, my understanding is that these interventions can be done with individuals as young as 18 years old. There is a separate intervention called trauma-focused cognitive behavioral therapy, TFCBT, that can be done with children. So that could be something to pursue if you're interested in that intervention.
Дякуємо. Ірина Яворська запитує, ви згадали, що можна працювати з ПТСР з військовими, яким слід повертатися на бойові позиції. Які техніки вважаєте найбільш небезпечними або гарантуючими, що така робота не нашкодить йому, не зламає його захисти, які допомагали під час бойових дій? На жаль, в Україні зараз це дуже часта практика, коли починається лікування, але потрібно, щоб пацієнт, клієнт повертався до виконання своїх бойових завдань. От які ваші рекомендації тут?
Yeah, and I think you negotiate that with your clients. So you can negotiate treatment with your clients. How ready are they to begin this healing process? But the argument that we make as therapists is, yes, it's challenging to think about doing therapy and then being redeployed, but it's also dangerous to have PTSD and then go back to combat as well. And so in my role as a therapist, I tell my clients, you will likely be more safe if we can help this PTSD resolve somewhat. And so at that point, it's the client's choice. If you're trained in these three interventions, what is the client interested in? What are they willing to try? And then how fast can you go through these interventions? So written exposure therapy could be done in 5 days. Prolonged exposure therapy, in the greatest extent, could probably be completed in a week. written exposure therapy, cognitive processing therapy, we would complete that in 10 days. So from what I understand, many veterans in Ukraine are redeployed within 3 weeks. So you could do a lot of treatment in 3 weeks if the client's ready.
Дякую. І переходимо до наступного запитання. Їх у нас ще багатенько, тому будемо намагатися відповісти на всі, або принаймні на ті, що встигнемо. Чи є специфічні психотерапевтичні стратегії для роботи з пацієнтами, у яких ПТСР супроводжуються залежностями? Алкоголь або психоактивні речовини? Якісь специфічні стратегії, так.
Yeah, absolutely. And so I'm very glad that this question came up. So when I think about working, because I do work with these clients in my own practice, and the question that's most important to ask is, how much is the substance use preventing the client from learning in therapy? So what I negotiate with my clients in therapy is, you can continue to use drugs, use alcohol, but you cannot increase the amount of substance use that you have. So if a client is drinking 6 beers a day, they cannot, in the middle of therapy, they cannot drink more alcohol, more than they are already doing. The client cannot come to session intoxicated, because that's going to interfere with the therapy process. And they also cannot use substances when they're doing their therapy homework. If the client is able to agree to that negotiation, then therapy can proceed. Otherwise, it may not be appropriate for the client to do treatment.
Дякую. Це не одне запитання щодо коморбідного ПТСР, ускладненого ще й адикціями, але я зараз хочу спитати вас про інший аспект. Чи є дослідження щодо ефективності когнітивно-процесуальної терапії у форматі дистанційної терапії по самостійним проходженням з мінімальним супроводом терапевта?
Yes. So if by remote therapy you mean telehealth or virtual therapy, yes, that is something that I have done with clients, and that's at the University of Texas at Austin. We also offer those services, both in person and virtual services using cognitive processing therapy. But whether we are talking about cognitive processing therapy or prolonged exposure, safety is obviously a question. Before we begin the intervention with our patients, we ask them, how supported and stable are you? Very often, clients begin therapy and they might experience more anxiety for a certain period of time. That's not a bad thing. And so if that happens for our clients, we want them to be supported as much as they can. And so that's an individual question for your client. But yes, it can be done virtually.
Дякую. Ми маємо питання від пані Лариси Дем'яненко, але, можливо, воно потребуватиме уточнень, то ми попросимо, якщо нам не вистачить для вашої розгорнутої відповіді, щоб пані Лариса уточнила. Щоб використовувати ці інструменти, треба отримати сертифікат про навчання. Напевно, мова йде про письмову терапію. Давайте спробуємо, чи нам вистачає тут контексту для того, щоб ви могли відповідати.
I believe so, yes. So that is a question that we are having as providers in the United States. So how much is it to be educated in an intervention versus being certified in an intervention? So for myself right now, I am trained in prolonged exposure, cognitive processing therapy, and written exposure therapy. But I am only certified in prolonged exposure therapy. But what I have done is get supervision. I think if one message I hope you get from this lecture is, if you're working with these clients, find a supervisor that can coach you. So for before I was certified in prolonged exposure, I worked with a colleague that supervised me so that I knew that I was ready to do this work with my clients. So certification is not necessary, but it can give the client confidence that you as a provider know what you're doing, if you want that.
Дякую. Я думаю, відповіді достатньо, але раптом необхідно буде уточнення, то нам точно про це напишуть. Ліза Осадча запитує, яка тактика дій під час роботи з пацієнтами, які є військовими та проявляють агресію щодо першої психологічної допомоги, коли вони потребують першої медичної допомоги, щоб такі пацієнти не нашкодили собі та оточуючим?
So when I hear that question, what comes to my mind, I don't know if this will answer the question, but I think it's about, does your clinic or practice have policies to handle aggressive clients? I know that when I have these patients, it's very important that I'm working with my colleagues. I am communicating very directly with my colleagues, my concerns, and we are coming up with plans for managing the treatment of these patients. But depending on the level of the aggression, I'm very direct as a provider. And so I often help my clients to identify that they're often using anger as a coping strategy, that anger is a symptom, extreme anger is a symptom of PTSD. And usually underneath that anger is tremendous grief. And so questions that I ask my clients are, how ready are you to approach that grief and begin to heal? And not to shame the anger. The anger makes sense based on the losses that people have experienced, especially the people in Ukraine.
Угу. Ще маємо таке питання, чи є щось, що ви раніше не використовували в роботі з ПТСР, а зараз вважаєте критично важливим?
So I think I use all of these interventions, but I would encourage you to pay special attention to the trauma themes modules in cognitive processing therapy. My practice in treating patients has become much stronger by bringing up those themes. And I think even in not PTSD cases, I think talking about safety, trust, power and control, esteem and intimacy, it's just good therapy in general. So if you decide to not do CPT, that's fine, but focus on those modules. They're very strong.
Як ви вважаєте, як впливає постійна небезпека, сирени, новини про загиблих, участь у бойових діях на здатність людини рухатися до відновлення? Чи можлива повноцінна робота з травмою в умовах, де триває загроза постійно?
Yes, absolutely. So I wish I don't remember the names of the researchers that did that work, but I'm aware, talking with colleagues, that there's been prior scholarship that have shown initial evidence that these trauma interventions can be used with people that are in theater, actively forwardly deployed in combat. And so I think that there's a question here, which is, does my client have to be perfectly stable to do this therapy? No, they don't have to be perfectly stable. And it's weighing the benefits and risks of treatment, right? So similar, if with a surgeon, right, you're talking with your patient, these are the benefits of treatment, these are the risks. What are you comfortable with? The same way with our client, these are the benefits of treatment, these are the risks of treatment. What is possible for you right now? So for clients that are under active bombardment, maybe it's possible for them to be to be treated. For clients that are forward deployed in active military operations, maybe not. But again, all we can do is weigh the pros and benefits and have our client decide what's right for them.
Угу. Пані Тетяна Цесаренко запитує, чи є протипоказання для застосування даних методик, окрім психозів?
A major contraindication is escalating suicidality or homicidality. You can work with, so if clients have passive or mild SI where they're thinking about it, but they're not planning it, they don't actually want to do it, these interventions may be appropriate. But if the client is continuing to self-harm and their thinking is escalated, you want to stop treatment and challenge that very often. It goes back to that question of stability. How stable is my patient for this recovery process?
Від пана Ігоря маємо таке запитання. Чи є специфічні лайфхаки, як вмотивувати пацієнта почати психотерапію? Психоедукація та проговорювання ризиків для пацієнтів під час стаціонарного лікування часто займає довгий час, який міг би піти на початок терапії. Можливо, у вас є вже напрацьований досвід, як спробувати швидко здолати стигму?
Yes, so discussing motivation is very important for all our PTSD patients. So very often I start the conversation with my clients by saying, what has PTSD cost you? So you're surviving with PTSD, but very often clients say things like, I can't connect with my spouse, I can't connect with my family or my friends, I feel numb all the time, I cannot enjoy my hobbies, and things that bring me joy. And so I often use I'm trained also in acceptance and commitment therapy, and I go back to values. What are your values? And how can we help you connect to your values as a way to move through the hard moments in therapy? So when my clients are struggling and we've identified what their motivation is, I might say something like, remember you're doing this for your family. Like why? And I ask them, why are you doing this? Come back to that answer. What is your value that you are practicing in therapy? And I often find that helps people to do hard things in therapy.
Дякую. І ще питання від Іоланти Маковської. Чи є якісь нові скринінги щодо експрес-діагностики ПТСР в умовах амбулаторного прийому?
So I'm going to pass this question to my colleague, Dr. Tanya Nicholson. My understanding is that her lecture in the future is going to cover this topic very thoroughly, and she's an expert, so I will leave it to my colleague.
Дякую, доктор Мюллер. Ми обов'язково зафіксуємо це питання і на вебінарі з Танією Ніколсон обов'язково його поставимо. Питання від Олександра Сиворотки. А якщо написане викликає сильні негативні емоції, як з цим працювати?
Yes, that's another very common question that we have. And so I'm going to use a metaphor, even though metaphors are not always perfect, but I think it's appropriate here. So what I tell my clients to think about is that the writing activity in written exposure therapy is like a scary movie, a horror movie, right? And I tell them that the worst thing has already happened. The trauma has already happened. And the memory, even the memory of the trauma, even though it is uncomfortable, cannot harm you. It will upset you. It cannot physically harm you. And so as they're writing, similar to a scary movie, you can pause it at any moment. I'm writing, pause. I need to take a minute. I need to collect, compose myself. And then they hit play and they can start to write again. So I think using that metaphor can be helpful and encouraging them to pause and then take a moment and return to the writing as they need to.
Дякую. Сподіваюся, і Олександру це допоможе. Питання від пані Марії. Чи була потреба у ваших пацієнтів у повторному проходженні когнітивно-процесуальної терапії при ПТСР? І як змінюється її ефективність при повторному використанні?
Yes, so I have had clients that, so I think of that as coming in for a second treatment experience. So I haven't had that with CPT, but I'm thinking of a few clients over this past year where I've used prolonged exposure with them, where we start treatment, but something happens. Maybe they lose their job, or a relative might die, something that prevents them from continuing treatment. And so very often, or they're not motivated maybe too. And so sometimes they come back to therapy and they're able to commit more fully and have a more effective treatment experience. But that's why I think about my job similar to a physician with medication, right? So you prescribe an antibiotic once, and then later did that work or did that not work? Same, you do one treatment series with a client, you ask at that 12th appointment, did this work? Did this not work? And if the client has good motivation and is committed, they can move towards healing even if it takes more than 12 sessions.
Маємо ще питання від пані Олени, але я не впевнена, що до вас, тим не менше, можливо, ви щось порадите. Також цікавить питання спілкування поліцейських з ветеранами та військовими у стані агресії. Можливо, є якісь швидкі інструменти для деескалації?
And that's my understanding is that's aggression in the session, not aggression outside of session, correct?
Агресія за межами сесії – це коли ветеран або людина з бойовим досвідом, діючі військовослужбовці в спілкуванні з поліцейськими проявляє такий стан агресії. Можливо, є якісь такі поради швидких інструментів, яким можуть навчатися ті, хто контактують з людьми з ПТСР.
So what comes to my mind is the idea of harm reduction, right? So if a client is self-harming, we have methods of harm reduction that we do with them similar to drinking. And so I think what we can do in session is help our clients plan, like they can plan for the future. So if you encounter law enforcement or if you have aggression, how can we help you come up with your own policies for handling conflict? I did not include it in this presentation, but there is I forget the name of it, but there's an intervention for aggression and that you can do before the interventions that we talked about. I'm happy to see if I can provide that potentially in the future if people are interested in that. But that would add potentially 3 sessions onto treatment for our clients. And I'm not going to have a great answer, but I know in the United States, at least in Texas, we have really great training programs for our law enforcement officers where, again, I can't give details on that, but they're taught to handle these sort of things and how to de-escalate it. I think, so hopefully, maybe I can research that and get back to you. I wish I had a more thorough answer.
Добре, ми тоді дочекаємося, коли ви оновите одним слайдом вашу презентацію, і потім ми зможемо розіслати її учасникам вже з урахуванням цього модулю по агресії. Так? Домовились? Так, буде вам окей? Пані Тетяна запитує, чи впливає рівень інтелекту пацієнтів на ефективність терапії?
I would say it affects therapy no different than other forms of therapy, right? And so if we think about PTSD treatment as a learning intervention, so the question we ask ourselves is, can the client engage in the learning process? And I think challenges with learning happen across the continuum of intelligence, right? So if a client has lower intelligence, they might be very concrete. But I've also worked with incredibly intelligent people that fight the therapy process. So I think it can happen on both sides of how patients are functioning. So it's going to be an individual decision if treatment's right for that person.
Як ви особисто ставитесь до застосування VR-технологій в лікуванні ПТСР? Що вважаєте ефективним, якщо вже використовувати технології?
Yeah, so I have colleagues that do that work. That's actually an area of interest for me. I'm hoping to potentially build out a program using that technology at the University of Texas. The main advantage of that's an exposure-based technology. And the main advantage of it is that it's able to move the client into potentially dangerous or difficult to replicate situations. So I know I work with a lot of clients that are afraid of having a panic attack on an airplane. So that's something that I'm interested in having them. Or I know that I believe it's Dr. Rothbaum, where she looks at, I believe she's at Emory University in the United States, using technology related to combat circumstances, virtual reality technology. So she might be someone to look up if you're interested in that.
Дякуємо. А як ви ставитеся до арт-терапевтичних технік і їх застосування як допоміжних методів в лікуванні ПТСР?
I'm going to sit with that question for a moment. I think what comes up for me, so I do art myself. So there's this was not what was asked, but there's also a question here. How do we take care of ourselves as therapists? Being a trauma therapist can be very challenging. And so I know that in my own life, I benefit from creating art. I think creating art is a way to remind ourselves that the world is still beautiful and that there's still goodness in the world. So for clients that we work with that are artistic, it can be a great intervention. But while it can make the client feel better, it may not resolve avoidance. It may not resolve the trauma symptoms. So interventions like art therapy can be very beneficial, but I would not use them primarily with the client. I would want to use one of these evidence-based interventions first.
Доктор Мюллер, ми з вами я вам зможу поставити ще 2 питання, щоб ми були в таймінгу, ви на них зможете відповісти. Тож від пана Дмитра маємо таке запитання: які проєктивні методики можуть допомогти?
I'm going to defer that to Dr. Israel Lieberson. I know he's an expert in those interventions. So I'll let my trusted colleague take that question.
Добре, ми тоді так само зафіксуємо. У нас наступна лекція буде з доктором Ліберзоном, і ми, пане Дмитро, точно поставимо це ваше запитання. Тож вам раджу, пане Дмитро, доєднуйтесь до нашої наступної зустрічі з фахівцями з Техаського університету і будемо розкривати цю тему лікування ПТСР ще більше і глибше. Від Альони Цвіткової: які методи варто застосовувати для військових при порушеннях сну та нічних кошмарах?
So several interventions. One of my training goals this year is to get trained in a variety of interventions. So you have cognitive behavioral therapy for insomnia, CBTI. I have a colleague here at the University of Texas that does that. There's also there's a nightmare, CBT for nightmares, a nightmare protocol that you can use as well. So while I'm not trained in those interventions right now, you can always independently research those as well, from what I understand. Now, the challenge is we can use many interventions with our clients that have problems, but it will delay the treatment process. So if we do cognitive processing therapy, that's 12 sessions, and then we do a nightmare protocol, maybe that will take 6 sessions. It can very much extend the treatment experience. So we just need to be very thoughtful about how we're programming the treatment series so that our clients are benefiting, resolving their problems, but also doing it at a pace that works for them.
І останнє питання, яке вам сьогодні поставлю, але вони ще сипляться, тим не менше. Які особливості вашої роботи з пацієнтами, які в групі ризику до суїциду?
And by, do we mean how are they presenting in session? Is that how we should interpret that question?
Ну, так, якщо у вас є пацієнти, яких ви лікуєте, пацієнти з ПТСР, яких ви лікуєте, і в них високий ризик суїциду, які ваші ви застосовуєте особливі методики?
Yes, so I have several of those clients right now, and I am very direct with them. I'm consulting very quickly with my colleagues. I want them to have a circle of support around them. I want our administrative staff to know that they're in our clinic so that if they call in, we can immediately respond to them. I'm doing safety planning with them in session as well. I'm providing them with local crisis resources, and I'm helping them to identify what keeps you safe and how can we build those opportunities for wellness and safety. And also, there's a question there as well, which is how stable is the patient? If a client can be passively suicidal and still do PTSD treatment, but if that suicidality or self-harm is increasing, getting more severe, I will not continue PTSD treatment. I will pause treatment until the client is stable enough.
Дякую, доктор Мюллер. Дякую вам і за лекцію, і за те, що ви відповідали на запитання. Я дякую нашій аудиторії, нашим учасникам за те, що вони були активні, за те, що ставили запитання і були з нами 1,5 години на зв'язку. Нагадаю, ми були в прямому ефірі на Фейсбуці Координаційного центру з психічного здоров'я Кабінету міністрів України і в Зумі. Я ще маю подякувати за те, що сьогоднішній вечір, принаймні в Києві, був без повітряних тривог, тож наші фахівці, наші учасники, які доєдналися сьогодні до цієї зустрічі, змогли спокійно віддатися тому, щоб вас слухати, отримувати нові знання, в чомусь з вами звірятися або мати сумніви, дискусії, ставити запитання. Тож, дякуємо вам і бережіть себе, і щохвилини думайте про те, якою цінністю є мир. Дякую вам, дорогі учасники, і тихого нам вечора, і тихої ночі. До побачення.